Okay, so today we're going to talk about lung cancer screening. So we'll do some introductory stuff about criteria for effective screening, do a brief history of lung cancer screening, and we'll talk about low-dose chest CT, the lung cancer screening trial, that landmark study that determined the benefit of CT for lung cancer screening. Then we'll talk about the newest version of Lung-RADS for scoring lung cancer screening cases, Lung-RADS 2022. So the common sense approach for lung cancer screening, so lung cancer is the leading cause of cancer death, and we know that CT can detect small lung cancers less than 1 centimeter before they produce symptoms. So this is an example, initial CT, follow-up CT, very small lesion, we see that it's grown. And we know that resecting lung cancers when they are small should improve survival. So therefore, CT screening for lung cancer should save many lives. But it's not always as clear-cut as this because there are other factors to consider. First, there are criteria for effective screening. So the disease has to have serious consequences. So you don't want to screen for a disease that doesn't matter so much. And of course, lung cancer matters a lot, so it fulfills that criteria. The screening population needs a certain prevalence of detectable preclinical disease. And so here for lung cancer screening, we're talking about asymptomatic patients. They should have at least 10 pack years history of smoking. Age should be at least greater than 40. Prevalence, we're looking for something around those numbers there for screening. And screening should detect little pseudo-disease. So what is pseudo-disease? Pseudo-disease is disease that progresses very slowly, that is not clinically significant. So the problem with screening studies is you can always detect indolent tumors that may be very slowly progressive and may not matter in terms of that patient's life expectancy. So the patient doesn't die because of the cancer, they die with the cancer. So screening allows you, because of the nature of it, you can detect smaller lesions that may be indolent and not matter so much for the patient. Oh, you can only prove whether that really occurs or not if we actually do a study, a randomized controlled trial, as we'll talk about. Screening should have high accuracy for detecting the preclinical phase of disease. So you need a very high sensitivity. Ideally, you'd want a low specificity because you don't want to deal with working up all the false positive cases. And then, we do have numbers for the sensitivity and specificity of CT for screening for lung cancer, but much of that depends on your threshold for what you call a positive result. And we'll talk about how the threshold affects that. And you would, of course, want the screening to detect disease before the tumor metastasizes. So you'd want to be able to get the tumor when it is curable. The screening itself, you don't want that to be harmful. So with low-dose CT, we're talking about doses of 1.5 millisievert. Still, even at that low dose, there's still some theoretical risk of inducing cancer. So you don't want the screening itself to be harmful, especially if you're going to expose a very large population to that. The screening should be affordable and available, and there should be effective treatment for whatever disease that you find. And the treatment should be more effective when applied in the preclinical phase. You don't want the treatment to be too risky or toxic. Working up a whole bunch of false positive cases can also add morbidity, so that's also a problem. And the 30-day mortality after resection for lung cancer is on the order of 3.7%. So even when you resect these lung cancers early, there is still a certain morbidity and mortality that is associated with the procedures itself. So procedure itself has complications. So if in our experimental screening trial for lung cancer, we find the following results: screened patients, 5-year survival is 65%, unscreened patients, 5-year survival is 35%. This proves that screening works, right?
No.
Why not? So that's the point, is that there are these complicating factors that can be associated with screening. One of them is lead time bias. So if you have two populations, the population that is unscreened and the population that is screened will assume that screening does not really affect the mortality at all. So, the mortality rates will if they are the same. If you don't screen the patient, you pick up the disease much later in its natural history. So the survival from when the diagnosis is made is shorter. Whereas if you do pick up the disease with screening, you've picked it up much earlier in its natural history. And even though picking up the tumor early with screening does not affect the mortality of that patient, the survival, though, will be longer from the time of diagnosis. So that is called lead time bias. So even though the screening makes no difference in terms of the mortality for the patient, those patients, when they're diagnosed with cancer, will be diagnosed earlier, and so they will appear to survive longer from the time of diagnosis. So that's called lead time bias. So that's a complicating factor that you have to account for. If in your experimental screening trial you find that the incidence of lung cancer is higher in the screen group compared to the unscreened group, so how is it that the incidence of cancer is higher in the screen group compared to the unscreened group? What is that called? It's always useful to know who has reviewed the material that I've sent out a week ahead of conference. So that is called length time bias. So we talked about the screening being able to detect indolent tumors, tumors that grow very slowly. So if you have rapidly progressive disease, that will present with symptoms. But if you have very slowly progressive disease, that can be going on for a long time in your population. So if you're screening at regular intervals, you're more likely to catch the slowly progressing disease rather than the rapidly progressing disease. That's called length time bias, and that is related to what we call overdiagnosis bias. So in these unfortunate diagrams here, this represents patients who have expired. You can see that. So let's assume that screening and whether patients are screened and unscreened, that it doesn't matter in terms of the overall mortality rates. Okay, but what happens is that we might have a tumor that is detected in the screen group that the patient doesn't die of the tumor. The patient dies of something else because the lesion itself is so very slowly progressive that it really doesn't affect the life of that patient. So the patient dies of something else. So they don't die with the disease, they die with the disease, not of the disease. And so in our statistics, though, we will pick this up as a diagnosis of a cancer. So it will seem like the patients that we screened have a higher rate of lung cancer than the patients that are not screened, because these very indolent, slowly progressing tumors that the patient dies of something else, so the tumor is never detected at all in this group. So that's another problem with screening, is overdiagnosis, and we'll talk about that too. When comparing survival of lung cancer between screened and unscreened patients for stage 4 lung cancer, you find that in the screen group with stage 4 lung cancer, the survival is 20%. But in the unscreened group, the survival is only 5%. How is that possible? Stage 4 cancer, they survive longer in the screen group versus the unscreened group. How is that possible?
Stage migration.
So that is called stage migration bias. Right. So what happens is, because you're screening the patients, you are detecting the disease much earlier in its natural history. So when you're detecting metastatic disease in these patients, you're detecting it much earlier in the natural history of the disease. So those patients will, in the more advanced stage, will seem to survive longer. Again, that's a lead time bias, only it's applied to staging. And so this also results in a stage migration bias, as you will find that since we're detecting the advanced tumors very much earlier, patients tend to be upstaged when they are screened. So the silent metastatic lesions will be removed from the lower stages. So the lower stages of the screen cohort will appear the survival in the lower stages of the screened cohort appears greater than in the unscreened cohort. And then, same thing, the survival in the higher stages of the screened cohort appear greater than in the unscreened cohort, because in the cases of metastases, you're going to detect them much earlier along the course of disease when the metastatic disease is very small. And so those patients will survive longer than if you detected them in the unscreened group, where they will naturally be more advanced by the time they present with symptoms. So that's called stage migration bias. In comparing mortality between the screened and unscreened groups, you find that cause-specific mortality rate for lung cancer is significantly lower in the screened group. So now we're looking at cause-specific mortality from lung cancer. If we assume that the financial cost of screening is acceptable, is that enough to assume that screening is beneficial? We show that, well, in the screened group, the mortality from lung cancer is less. Are we good? Or is there something else to consider?
All-cause mortality?
Why?
Because, I mean, the screening test itself could, like, more radiation.
So that's correct, is that the problem is maybe the screening itself introduces some kind of harm, some other type of harm that you're not going to detect if all you're looking at is the incidence of lung cancer. So the cause-specific mortality rate is what is the most definitive measure of the efficacy of screening. That's what we're going to look at. So you need to compare the cause-specific mortality rates in screened patients versus unscreened patients. And if the therapy in early phases of disease is effective, that should reduce the cause-specific mortality rate in the screened group. So if screening is effective, if it is effective, it should decrease the cause-specific mortality rate, because that's going to remove lead time bias and all of that. But you also need to look at the all-cause mortality rates, because you want to make sure that the screening process itself does not introduce harm that you're missing. So if you are saving enough lives, the overall mortality rate should decrease if screening is effective. But if there are unaccountable differences in the mortality rates, then one problem that could be is a bias in randomization. But another problem is that the screening test itself might affect the natural history of other diseases. So remember, for lung cancer screening, we're using radiation. So what if the screening itself accelerates the natural history or the history of coronary artery disease, breast cancer, or introduces other types of cancer? And so you're not going to pick that up if all you're looking at is the cause-specific mortality from lung cancer. You need to look at all-cause mortality to make sure that you're not introducing any harm in your population by the screening procedure itself, especially if you're using something like radiation. So let's talk about a brief history of lung cancer screening. So the studies here were done using chest radiographs, and these are the centers where those studies were done. And so they used various combinations of screening, chest radiographs, and sputum cytology for early detection of lung cancer in smokers. The Mayo Lung Project was the most famous of these. So here the criteria: greater than 45 years of age, greater than 1 pack per day of smoking. So in the study group, patients had chest radiographs and sputum cytology every 4 months for 6 years. Chest radiographs every 4 months. In the controls, of course, no intervention. These are the number of subjects. These are the number of lung cancers that were detected. They did find that the lung cancer in the study group were at an earlier stage and more likely to be resectable, so that's lead time bias, that's what you would expect. But when they compared the statistics, no difference in lung cancer mortality statistically between the two groups. So the study was criticized because it may have had low power. Look at the number of subjects. Maybe there might still be a benefit there that it was not detected because of the number of subjects was not large enough. So there was a larger trial, and this larger trial was done as part of screening for multiple diseases, the PLCO randomized trial. Who knows what these letters stand for? P? What tumor would that be? Prostate, right? L? Lung cancer. C? Colon. O? Ovarian, right. So this was a randomized trial looking at screening for these cancers. And so they followed them for up to 13 years. The intervention, baseline and annual chest radiographs for 3 years. And of course, the controls had no intervention. And then here, retrospectively, years later, they went back and looked at a particular group of patients that would have been eligible for lung cancer screening with CT, with the study that came much later, to compare that particular subset to see if chest radiographs in that particular subset would have made any difference in terms of the mortality from lung cancer. Again, no significant difference in lung cancer mortality. So this study did have a higher power. So it seems that chest radiographs by themselves are not good enough to use as a screening tool to make a difference in terms of lung cancer mortality. So the idea for CT for lung cancer screening, this was from Claudia Henschke, and one of the early studies here was the Early Lung Cancer Action Program, abbreviated as LCAP. This is something you might come across in the literature. So this was done at NYU and at Whale Medical Center, Medical College. So very small study in the beginning, 1,000 patients, age greater than 60, 10 pack years. They did baseline and annual low-dose chest CTs, and they found that, again, no controls here. They were just looking at smokers. 85% of the cancers that were found were stage 1A. So that's kind of encouraging that the cancers that were detected here were very early cancers. So this led to the International Early Lung Cancer Action Program between those years, much larger study, over 31,000 subjects. Here again, 85% of cancers were stage 1A, 80% 10-year survival for all stage lung cancer, and 88% 10-year survival for stage 1 lung cancer. Again, this was not a randomized controlled trial. There were no controls. They were only looking at patients who smoked with CT. There was no control arm here. So, first question, what is a low-dose chest CT? Who can tell me what a low-dose chest CT is?
On contrast chest CT with lower MA.
Okay, and what's the difference in dose between a low-dose chest CT and a routine chest? 20% less dose? Is that right?
20% of the dose.
Yeah, so it's 80% less dose. So it's 20% of the dose of a routine chest CT, and we do that by lowering the MA, the milliamps. We don't change the kV. Those are the two factors that you really have control over on CT. The two major technical factors, the kV and the MAS, or the MA. So the kV we don't change between standard and low-dose CT, but we do lower the MA to about 1/5 of what we would use for a normal full-dose CT scan. So both are done with thin section imaging. You can see how the doses might compare. And so with a low-dose CT, we find that the images are much noisier, but it's good enough because there's very high contrast within the lungs. There's natural high contrast between the lung parenchyma and any kind of lesions, any nodules or lesions that you might see in the lungs. So because of the inherently high tissue contrast in the lungs, low dose works out very well. Now, obviously, you wouldn't want to do this for the liver because you get very, very noisy images. So here, compare what the soft tissue windows look like, full dose CT versus a low dose CT. You can tell that this image is very noisy, looks very granular here. Right? So that's the noise in the soft tissue windows. But when we're looking at the lung windows, and we're trying to pick up small nodules and lesions, it's pretty good. There's enough inherent contrast within the tissue itself that we can pick up these nodules pretty well, even on a low-dose chest CT. So that's what a low-dose CT is. Now, for those of you from St. Barnabas here, before payment for screening CT was approved, and before payments were made by insurance companies, St. Barnabas was offering this for free. Why? What's the benefit of that? Isn't that a money loser? How do you justify that to the CEO of St. Barnabas? We're going to do free lung cancer CT. But what about the bottom line?
Don't bring in what
Even better than that, because the number of cancers that you're going to find are pretty small. If you find a nodule, what happens? You have to follow it up. That's right.
Yeah.
So whereas with screening, even if the insurance company is not paying for it, the patient doesn't have a diagnosis, they're asymptomatic. But if you find a small nodule, now the patient has a lung nodule. Now they have a diagnosis. So now the patient comes back for follow-up studies, and now the insurance company pays for it. So this was a strategy that was used early on, and also good PR, right? Free lung cancer screening, but it's not a money loser. So the landmark study to show that lung cancer screening with CT was beneficial, the first study here that actually demonstrated that, was the National Lung Cancer Screening Trial, and it was published in the New England Journal of Medicine in 2011. So this was the largest randomized study of lung cancer screening in high-risk population, and I believe it still is the largest in terms of numbers. So 53,000 participants. They had to have greater than 30 pack-year history of smoking, 55 to 74 years of age. They had to have smoked within the past 15 years. And there were only 3 annual screenings. So there was a baseline study, a screening study 1 year later, and then a screening study 2 years later. So it's based on basically these 3 CT scans. All of the data is based on just that. And then these patients were followed for a number of years to determine if there was any difference in terms of the specific mortality from lung cancer and overall mortality. The cost was about $250 million, $250 million, which even back then was a lot of money. Criteria for a positive CT, nodule greater than or equal to 4 millimeters, and the primary endpoint was lung cancer mortality. Of course, they had all the data there they were collecting, so they could look at all kinds of other secondary endpoints, of course, all-cause mortality, incidence of lung cancer, all of this stuff, of course, they were also able to look at from the data that they collected for this study. So what were the results? It was the first screening study of lung cancer to show reduction in lung cancer mortality from screening. So the number is 20%. 20% relative reduction in mortality from lung cancer screening in the screened group. Small overall reduction in mortality also in the screened group. And you needed 320, the number needed to screen. 320 needed to screen to prevent 1 lung cancer death. And when this was published, all of these organizations, basically lobbying organizations, but all of these organizations, took the study and became very active and started asking for the government, through Medicare, Medicaid, and insurance companies, to pay for lung cancer screening, since now we had evidence that lung cancer screening does reduce mortality from lung cancer. Now we have hard evidence for that from that study. So we should pay for lung cancer screening for everybody who's eligible. So now look at the timeline for coverage for approval of lung cancer screening. So these are what these abbreviations stand for over here. So the screening trial results are reported in 2011. So the United States Preventive Services Task Force here, a couple of years later, makes a recommendation, and the recommendation is that yes, it should pay for lung cancer screening. Medicare then reviews this, 2014, and at first they decide not to cover lung cancer screening. That created quite an uproar at the time, that these people on the committee don't care about people's lives, they're just bean counters, just care about money. And so that's why, there were no radiologists there to decide and all that stuff. So we'll talk about the reasons why they made that decision, but eventually that was reversed because there was a great uproar about that. So Medicare finally decides to cover lung cancer screening, Medicare and Medicaid. And so then the private insurance companies have to follow suit, and then there's final approval for covering lung cancer screening. So now that service is paid for and covered as part of accepted screening procedure. Now, why initially when they looked at the data from the lung cancer screening trial, did they decide, well, there's not enough evidence yet to justify this, applying this to a large population? Well, this was also data from that lung cancer screening trial that was also there. So if we look at this, at the time that they made the decision, there was only one randomized control study, which is the lung cancer screening trial, and only 25% of the patients in that study would have been Medicare eligible. So what was the cost? The benefit, of course, is to prevent 83 deaths from lung cancer. That was the benefit in the group that was screened. What's the cost? The cost was 75,000 screening CT scans, over 8,000 CTs, follow-ups for positive cases, probably didn't turn out to be cancer, over almost 1,500 PET CTs, 322 biopsies, 671 bronchoscopies, 713 surgeries, 228 complications, 16 iatrogenic deaths, 6 iatrogenic deaths in patients who did not have lung cancer. And theoretically, if you apply radiation risk, you can theorize that there might be 8 radiation-induced cancer deaths, a conservative estimate based on the amount of radiation that this population was exposed to. So looking at this, the initial reaction for Medicare was, gee, maybe there isn't enough evidence yet to justify using this for these large population. But that decision was eventually reversed, and now it is an accepted screening procedure. So the Preventive Services Task Force recommendation recommends, this was in 2013, since then there was a small difference here, and we'll talk about that. So they recommended annual screening for lung cancer. This is a grade B moderate benefit. Patients greater than 30 pack year history, 55 to 79 years of age. They had to have smoked within the past 15 years. So if they quit smoking 10 years ago, they're eligible. If they quit smoking 16 years ago, they're not. Now, since then, there have been other trials, controlled trials for lung cancer screening. There were 7 European trials, over 37,000 subjects. The most well-known of those is the Nelson trial. And so there are some results from that. The Nelson trial here also showed a reduction in mortality. So the mortality for benefit for screening, 26% reduction in mortality for men from lung cancer, 39% reduction in women. That difference between men and women has never been really explained, why there was such a difference there. But at least this also replicated some of the results from the National Lung Cancer Screening Trial, that indeed screening for lung cancer with low-dose CT does result in reduction in mortality from lung cancer. Now, we talked about overdiagnosis, and there's some estimates as to what the rate of overdiagnosis is for lung cancer screening. So it's estimated that 30% of the lung cancers detected with screening are overdiagnosed. In other words, 30% of those cancers that are detected are not going to affect the lifespan of that patient. Now, how does that compare with other screening methodologies that are accepted? For breast cancer screening, the overdiagnosis rate is estimated to be between 30 and 54%, and for prostate screening, the overdiagnosis rate is estimated here between 29 and 44%. So indeed, for lung cancer screening, it falls within the range of what is acceptable when you compare it to other types of screening procedures that are widely accepted. Now, in the most recent recommendation by the U.S. Preventive Services Task Force in terms of patients who should be eligible for lung cancer screening, so the basic idea was to increase the number of patients who would be eligible for screening, to make this available to more patients. What does that mean? Well, they reduced the number of pack years, so now it's greater than or equal to 20 pack years. They increased the age range, 50 to 80 years of age. They still had to have smoked within the last 15 years. And also it's important to offer smoking cessation intervention for current smokers. So that's also a requirement, is that the clinician who is ordering the study must talk about smoking cessation with current smokers. So the patient criteria for Medicare and Medicaid, there's still a 20-pack year history, 50 to 77 years of age, smoked within the past 15 years, absence of signs or symptoms of lung cancer. So the clinician has to document that the patient is asymptomatic for lung cancer at the time of screening. The written order for lung cancer screening must be obtained during counseling and shared decision-making, so that also has to be documented by the clinician. So the clinician has to discuss counseling on benefits, harms, diagnostic testing, and smoking cessation with the individual before approving a lung cancer screening CT. Now, for Medicare and Medicaid to reimburse a center that does lung cancer screening, there are certain facility criteria. The CT readers must be ABR board certified or board eligible. The CT-DI vol for a patient of that weight must be less than or equal to 3 milligray, and most are. You must use a standardized lung nodule reporting system. That's why we use Lung-RADS. And they used to require submission of data to an approved registry, where all of the data that you collected during the screening of these patients had to be submitted to the registry, but that is no longer required. So that no longer is a requirement. So things that you have to look at in terms of the radiation dose, you have to keep the CT-DI vol less than 3, so you got to look at that. And you want to keep the DLP here less than 105. So you want to look at that also on your dose reports. And then the registries actually also keep track of this. The data that you submit to the registry will keep track of the radiation doses that you're exposing your patients to. Now, structured reporting is also very helpful for these. That's why we use a structured report here. So you must, now these are requirements to get reimbursed. So that's why the structured report is very helpful, because it is required that the report contain this information to be eligible for reimbursement when you do a lung cancer screening CT scan. You must document the clinical indication, age, and pack year history. So that's why we have to include the pack year history. What's the pack year history of the patient? The CT scanner used. That's why we have to include the serial number. So every CT scanner has a unique number that is used for screening. So you must document that also. We also need to document all of these technical parameters, which is why we have to put in the DLP, the CT-DI vol, the pitch, KV, MA, scan time, rotation time. You'll find that in our protocols, the scan time is usually fixed, the KV is usually fixed, so you guys don't have to enter that when you're going through the template. But you will enter the things that will change. You will enter the DLP, the CT-DI vol, the MA. Rotation time is standard, that you don't have to change. The scanning volume. What's the scanning volume? For those of you who are reading the lung cancer screening CTs, almost everybody on chest reads these. Come on, what's the scanning volume? Don't remember? That's the length of the scan in centimeters. All right. What's the length of the scan in centimeters? That's what we put there for scanning volume. Every nodule gets a unique number. So every nodule gets a number. You have to give the size of the number, the consistency. What do we mean by consistency? Yeah, is it solid? Is it ground glass? Is it mixed attenuation? And of course, the location. Where is it? What lobe is it in? So if on your first screening study, the patient has one nodule in the right upper lobe and one nodule in the right lower lobe, the nodule in the upper lobe gets number 1. The nodule in the lower lobe gets number 2. If they come back and they develop a new nodule in the right upper lobe, that gets number 3. So each nodule has a unique number that is going to stay with that nodule for the duration of the patient's screening history. Okay, so you want to don't mess up the numbers, or you will create nightmares for people who have to follow your screening at the next screening interval. And then we give an overall Lung-RADS score, and the thing about Lung-RADS is it also tells us about management for the patient. So on a screening CT in a smoker, you find this 5 millimeter nodule. What's the positive predictive value that's a lung cancer? High or low? How low? Very low, even lower than that. In the National Lung Cancer Screening Trial, remember their criteria was 4 millimeters. 24%, almost a quarter of all the patients they screened had nodules, but they were small nodules. Right? So in the long run, over 95%, about 96% of those were false positives. They were small nodules, they were probably inflammatory, and were not lung cancer. So the specificity then is low, because most of the nodules that you're going to detect, especially as you make your threshold lower and lower in terms of diameter to call a positive nodule, most of what you find then for the small nodules are going to be benign inflammatory lesions. So what can we do to decrease the false positive rate? So remember, we said that in the National Lung Cancer Screening Trial, the criteria for a positive result is 4 millimeters. What's the criteria for positive result when you're using Lung-RADS? 6. So that's why we increased the number to 6. So if we look at what happens here, so in this study they went back and looked at the data from the National Lung Cancer Screening Trial and say, what if instead of using 4 millimeters, we make it 6 millimeters, we go higher. Well, 51% of all nodules were between 4 and 6 millimeters, but if you increase that to greater than 6 millimeters, then you decrease the number of nodules that you're going to consider positive. It goes down to 30% of nodules. But the positive predictive value, at least it becomes greater than 1%. So even using that threshold, your positive predictive value is still only 1.7%. So it does reduce your sensitivity somewhat, for detecting lung cancers, but it does result in many less false positive cases. And with false positive cases, there's also the workup and the anxiety that patients have to go through. So that's why, even though 4 millimeters was the number that's used in the National Lung Cancer Screening Trial, as far as Lung-RADS goes, and currently we use 6 millimeters as the threshold for what essentially is a positive result, at least at baseline screening. Okay? So we give these patients a score based on the interpretation of the lung cancer screening study. So we'll give them a score using these Lung-RADS categories. And the advantage of that is it also determines management. So a score of a 1 or a 2 is essentially a negative result in the sense that it doesn't affect management. So the patient will just come back for their next screening in 12 months. A score of a 3, well, now we're a little bit worried, but still probably benign. So there, we're talking about nodules between 6 and 8 millimeters. The follow-up there is 6 months. Once we get to a score of 4, now we're worried a little bit more about lung cancer, so the nodule itself is larger here. And then the follow-up here is 3 months, but there, you have other options also. If you're more concerned about lung cancer, it gets a 4B. And if you're really concerned because you might have lymphadenopathy or evidence of metastatic disease or a really ugly spiculated nodule, and you might give the patient a score of 4X, meaning, gee, this is pretty much, we really think this is lung cancer. Now, the options for when you give a score of 4, a lot of you guys, what you do is that you kind of cut and paste the options here where it says low dose CT in 3 months, CT with contrast, PET CT, or tissue sampling. And you just put that in the recommendation, right? But that's not what you're supposed to be doing. What you're supposed to be doing is looking at all of these options. And for that particular patient, what do you think is the best option, okay? I mean, I really get aggravated when I see this, CT with contrast, right? You see a 7 million, you see a 1 centimeter nodule or something like that, and you're going to recommend a CT with contrast. Is that really going to make a difference in terms of, and then, clinicians follow your recommendation, they order a CT with contrast, and I have to go back to them and say, no, do something else. That's not going to help in this case, okay? So please be aware of that for the particular patient, even though these are the various options that are available to you, try to decide what makes the most sense for that patient. If it's a small nodule that we're not really going to be able to biopsy, or very difficult biopsy, maybe it's best to just bring the patient back in 2 months and see if it grows. Then you would do that. If you have a nodule that has a large enough solid component that you think PET CT would be helpful in showing whether there's activity in the nodule, then you can recommend PET CT. If the nodule is larger in the periphery and we think that, gee, this is really amenable to biopsy, we're really suspicious about this really needs to be biopsied, then you would recommend biopsy. Sometimes I offer both. I'll offer the clinician the option of a 3-month follow-up CT or a PET CT, okay? But try to decide, based on these recommendations, what you think is going to be best for that particular patient, okay? Don't just cut and paste all of them into your impression. Now, in terms of these primary categories, so all of these also have a certain relationship in terms of what is our expectation of cancer. So for a small nodule, for a score of 1, we expect less than 1% of those to be cancer. And the expectation of cancer, the probability of cancer goes up, obviously, as your score goes up. Another thing you need to be aware of is the S suffix that you can also add to your score. So remember that we're not just looking at the lungs, we're also looking at all kinds of other stuff. So if the S suffix you add, if there is a significant non-lung cancer finding on your scan. So let's say the patient has no nodules at all, right? So they would get a score of 1, but we see a renal mass, and that's going to require a workup, maybe a follow-up ultrasound, maybe a follow-up CT. So that patient would get a score of 1S, and you would need to alert the clinician that, look, there's another finding on the scan that is not lung cancer related, but will affect the management for this patient, and that needs to be pursued, and so we add the S thing. One other thing that's interesting is we have this category of 0. So 0 can be used if you have an incomplete study, let's say for whatever reason they left off the bottom 5 centimeters of the lungs. Well, I've got to look at that, so we have to bring the patient back. So there you can use the category 0. Or if we know the patient has prior studies and we would like to compare with the prior studies to give us a better accurate interpretation of what nodule we're looking at, you can use the category 0 if you expect to get hold of the prior studies. But another interesting application is sometimes you'll find lesions that really look inflammatory. And so you think, well, this really looks like an inflammatory lesion. You know, if we bring the patient back in 1 to 3 months, maybe it'll go away. And if it goes away, that of course changes the management for that patient. So for that particular scenario, you can also use the score of a 0 in your lung cancer screening score. So that's likely infection. That's a score of 0. And then this, the cheat sheet, of course, you're not expected to memorize this, so these cheat sheets are available, right? They're on every PC in the special folder that contains all the various cheat sheets that you guys should be using. So please make sure you're using Lung-RADS 2022, okay? And it's very easy to use, so you can use this in terms of your scoring. If you have any questions, ask me or ask the attending that you're working with. So Lung-RADS 0 you can use for infection. The mean nodule diameter should be measured to 1/10 of a millimeter. Now, how do we calculate the mean nodule diameter? You give these numbers for a lung nodule, 5 millimeters, 5.1 millimeters. How do we calculate that? What do we do to get the mean nodule diameter when you're reading these studies? No idea? So you measure it in all 3 dimensions?
Is that what you do?
No. No. You take the 2 largest dimensions of the nodule. You take the 2 largest dimensions of the nodule and you average them. All right? That's how you arrive at that number. And you should do it to the nearest 1/10 of a millimeter. I tend not to do that, not to go to the nearest 1/10 of a millimeter, but it does make a difference because if you can turn a 6 millimeter nodule into a 5.9 millimeter nodule, that changes the management of the patient. Okay? So remember, a 6 millimeter nodule is going to be a score of 3, but a 5.9 millimeter is a score of 2. Okay, So that's where that can become important. So mean nodule diameter to the nearest tenth. Periphyseal or pleural-based nodule, that can be up to 10 millimeters if it has features of an intrapulmonary node, something you're not worried about. So you can go up to 10 millimeters there, and that patient can still get a score of a 2, which means that they will not get a follow-up CT for another year. And then for nodules that are pure ground glass attenuation, as long as they're less than 30 millimeters, that still can get a score of a 2. If the whole nodule, if it's a pure ground glass attenuation lesion. Okay? So here's an example of the inflammatory stuff. So here's a patient who had these ground glass opacities. This one looks a little worrisome, has maybe a solid component here. Gee, what's going on? But really you get the impression that maybe there's something inflammatory going on. You bring the patient back in a couple months, and this gets better, right? You see that now it's purely ground glass there. So that's how you can use the score of 0. If you think these abnormalities are inflammatory, and rather than get the patient involved in a whole kind of workup, let's just bring him back in 1 to 3 months and see if these get better, right? That's a score of 0. Juxtapleural nodules. So these nodules, these periphyseal nodules or subpleural nodules, if they look like intrapulmonary nodes, you can go up to 10 millimeters there, and that's still a score of 2. Okay? Now, they also bring up atypical, they discuss atypical pulmonary cysts, and that gets you a score of a 4A, or if it's growing, 4B, and we'll talk about atypical pulmonary cysts. The criteria for growth, 1.5 millimeters or greater than 2 millimeters cubed, if you're actually doing volumetric analysis. 1.5 millimeters is the cutoff for growth. Okay? And the other thing is they've clarified this idea of stepped management. So the timing of the follow-up imaging is from the date of the exam being interpreted. So if we had somebody who had a score of a Lung-RADS 3, okay, at baseline, next follow-up for that patient should be in 6 months. But let's say at 6 months they come back and this lesion has not changed. Well, now that lesion gets downgraded to a Lung-RADS 2. And so the question is, well, when should their next follow-up be? Should their next follow-up be a year from this scan, or should it be a year from this scan? Well, it's going to be a year from this scan. Lung-RADS 2, follow-up is in a year, and it's a follow-up from the most recent scan that you've done. So this was confusing in the old scoring system. Now they've clarified that the follow-up is from the most recent scan that is interpreted. So here's an example. So on the initial CT, we have a 10 millimeter nodule. Patient gets a Lung-RADS 4A score, which means they come back in 3 months for this one. They come back in 3 months, the nodule has not changed. That gets downgraded to a Lung-RADS 3. And the follow-up for a Lung-RADS 3 is 6 months. So the patient comes back 6 months after this scan, for this scan, and it's still unchanged. It now gets downgraded to a Lung-RADS 2. Okay? So their next follow-up will be 12 months from this scan because it's a Lung-RADS 2. So that's the idea of stepped management, that the follow-up is based on the timing of the most recent scan that you're interpreting. Okay? And so this is the cheat sheet. Okay? It's very easy to understand and it's easily accessible. Answers a whole bunch of questions.
Okay, so continuing with lung cancer screening, the new screening criteria also includes a classification for atypical pulmonary cysts. And the reason why this is important is because 9.3% of lung cancers are associated with cysts. And in the Nelson screening trial, they found that almost a quarter of the missed cancers in that trial were associated with cysts, with these so-called atypical cysts. So what does this mean? Well, if we're talking about, first we have to define what an atypical pulmonary cyst is. If we have a unilocular cyst with the wall less than 2 millimeters in thickness, that's considered a benign lesion. But if the wall is greater than or equal to 2 millimeters, then we have an atypical pulmonary cyst. It may be multilocular, can be associated with lung nodules, there can be a nodule associated with the cyst. And the growth criteria, when you're following these, is greater than 1.5 millimeter increase either in the size of an associated nodule or the wall thickness of the cyst. So if you have a unilocular cyst like this, with a very thin wall, less than 2 millimeters, that's a benign lesion. That's not considered an atypical pulmonary cyst, and that does not require management with the most recent Lung-RADS version that we have. On the other hand, if we have a thicker walled unilocular cyst where the wall thickness is greater than or equal to 2 millimeters, as in these examples, then that's classified as a Lung-RADS 4A, and it will require at least a 3-month follow-up CT to see what happens to that. Now, you need to differentiate between a cyst versus a cavitary nodule. If the lesion is mostly air, then we treat it as an atypical pulmonary cyst. On the other hand, if the lesion has air in it, but it is mostly soft tissue, then we manage this as a nodule. So here you would measure the nodular component of the lesion and manage this as a nodule with the size criteria for that. So you can have multilocular cysts. So these may be thin or thick-walled cystic lesions with internal septations. So if we have internal septations or a multilocular lesion like this, even if the walls are thin, that still counts as an atypical pulmonary cyst. So that, again, would be classified as a Lung-RADS 4A lesion. Now, if there's growth of the cyst itself or the wall thickness or growth of any associated nodularity, then it gets upgraded to a Lung-RADS 4B. So here in these examples, you can see how the lesion grew from 23 millimeters to 28. And then here also we can see that there's been some increase in terms of the wall thickness of the lesion. So there it gets upgraded from a 4A to a 4B if there's any growth. We can also have nodules associated sometimes with these cystic lesions. So you can have an internal nodule, in which case it's considered an endophytic nodule, an external nodule, which would be an exophytic nodule. And this is managed by the most concerning feature. So if the nodule looks more worrisome than the cystic lesion, then you would measure the nodule and you would give the score according to the nodule and manage the patient accordingly. Now, if we have a nodule that has particularly any of these particular features, then we can move it to a 4X category, meaning that we are really concerned about lung cancer. What are those features? Well, if we have speculation, if we have lymphadenopathy, frank metastases, any ground glass nodule that doubles in size in 1 year. So those are all criteria. So that's for a category 3 or 4 nodule. With any of these additional imaging findings, we'll bump it up to a category 4X. Now, this also requires shared decision-making in terms of when the study is ordered. So you might ask the question, is it rational for a person at risk to refuse lung cancer screening? And this is something that is supposed to be discussed with the patients, talking about the benefits and the risks of screening. There's a very interesting card that actually is put out here where it can help in terms of understanding the statistics here. So if you have 1,000 people screened with low-dose CT for lung cancer, so this represents 1,000 people here, 3 lung cancer deaths will be prevented, and those are those 3 there, whereas 13 will die of lung cancer. So it's a nice graphical way of showing what these statistics really mean. So if you compare the unscreened population to the screened population, you can see the number of deaths. Most of the deaths occur from non-lung cancer related reasons. So heart disease and COPD are more common than lung cancer, and that results in most of the deaths. So when you look at the lung cancer deaths here, you can see that there's a a difference of about 3 if you screen 1,000 people between the screened population and the unscreened population. But the cost of that, all these false positive findings, invasive procedures, and the possibility of a major complication. So it is important to compare, what is the difference between relative risk versus absolute risk. So if we compare patients who were screened with CT versus patients who were screened with chest radiographs, looking at lung cancer, the lung cancer incidence there between those two groups, and then we also have the overall mortality here also listed. But the absolute risk of death from lung cancer in patients who are screened with CT does not really go down that much. So the risk from dying of lung cancer, the absolute risk is about 1.66% here in patients who are screened with chest radiograph, comparing with screening with CT. It only goes down by 1/3 of a percentage point, the absolute risk of for any particular patient. And also there's not that much change really in the absolute risk of mortality either. So the real difference between absolute risk versus what we talk about when we talk about we talk about relative risk a lot. There, the relative risk may go down by 20%, but the absolute risk actually goes down by a much smaller number. So the absolute risk reduction of death from lung cancer for patients who are screened goes down from 1.66% to 1.33%. And also the reduction of overall mortality is also quite low. So there's a difference between the effect this would have on a population, on a large screening population, which would be substantial, versus the effect for any particular individual. So for an individual to refuse a preventive measure may not be irrational. So if we say lung cancer screening with CT results in 20% reduction in mortality rate from lung cancer, that sounds pretty good, right? But if you say lung cancer screening with CT, and this is applied to the whole population, but lung cancer screening with CT results in only 0.3% reduction in mortality from lung cancer for any particular individual patient, that's the absolute risk reduction. That's a pretty small number. So maybe it's not irrational for people to decide that they don't want to go through the process of lung cancer screening. Now, the issues that require further study that still need to be worked out, the optimum population to screen based on the risk factors, what's the optimal age to screen, what smoking history, they've reduced it from 30 pack years to 20 pack years. Well, do we need to go any lower, et cetera? How frequently, how long to screen? So far we've been screening at 1-year intervals. Should that be lengthened? How many years do patients need to be screened? And what's the best definition for a positive nodule on CT? So we've talked about how, compared to the lung cancer screening trial, we increased that from 4 millimeters to 6 millimeters. Well, should that number get higher in terms of, and then that would further decrease the false positive rate. So these are all issues that still need to be worked out. Okay.